Welcome to endoscopy video. In this video, we're going to see a step-by-step poem for a patient with type 1 achalasia. So here we start the procedure with a Fuji 600 series standard endoscope with water jet and the standard channel, and we inspect the esophagus just before the procedure. So here we have a sigmoid esophagus with a very tight junction that you can see here. Significant force is applied in order to pass the gastroesophageal junction, and in the retroflexion we can see that the mucosa is in close contact with the endoscope. So the first step is to do a good submucosal injection at about 25 centimeters above the gastroesophageal junction, which is located at 40 centimeters. So here we have injected 10 milliliters of saline, and now we're using the ERBE Jet I-type knife for the incision. During the incision we can inject as much as we want with this knife in order to have a good submucosal caisson. Small vessels are coagulated with the endoscope using swift coagulation, effect 4 for the Vio 3 series. Obviously you can use other settings for coagulation, such as forced coagulation or spray coagulation. And the incision and dissection can be performed also with endocut. So here we have created enough space to push the cap of the endoscope and start tunneling. Here we have the ST hood by Fuji, which has a tapered tip, so the tip is narrow. We're performing anterior poem, so the orientation is at 2 o'clock, and the muscle at this moment is located at 12 o'clock. So we inject with ERBE Jet normal saline with 2 milliliters of methylene blue diluted in 1 liter of normal saline. So we proceed to dissection using either endocut or swift coag in this case, and we try to move very close to the muscle, which is located at the top of the screen. For dissection there are many settings that can be used, and to be honest, in every case I change the settings, I try different settings. The reason why I didn't use spray coag was because I had an interference between the use of spray coag and the screen of the monitor of my endoscope. So I'm using swift coagulation in this particular case. Now what I do is that I do an anti-clockwise rotation of the shaft of the endoscope. In this way we can simulate a posterior poem. That means that while we continue with anterior poem and the muscle in standard position is located at 2 o'clock, by turning the endoscope anti-clockwise we can position our tunnel at 6 o'clock or between 5 and 7 o'clock, and have the advantage of convenient positioning for dissection and then for myotomy. In case that we encounter feeding vessels, we can coagulate them with the tip of the knife. It is good to orientate the knife toward the muscle and not toward the side of the mucosa, because otherwise we're going to provoke mucosal damage, which is a very common complication during our initial steps in poem. So in order to avoid that, coagulate close to the muscle, and don't hesitate to use a coag rasper or biopsy forceps for better coagulation effect. For example, here I'm using the coagulation forceps by Pentex, which is a bipolar coagulation forceps, and it is ideal for coagulation close to the mucosa, because coagulation is applied only between the forceps, between the two metallic part of the forceps, and the tip of the forceps does not coagulate the nearby mucosa. So only the tissue that is grasped with the forceps is coagulated. From time to time, we have to extract the endoscope for the tunnel in order to confirm good positioning and good orientation of the tunnel, and also have an idea of how deep we are and how close is the gastroesophageal junction. Now we have a good dissection plane. We have a thick distended submucosal space that separates the mucosa, which is located at 12 o'clock, and the muscle layer, which is located at 6 o'clock. I repeat that in this particular case, I have modified the procedure, and despite the fact that it looks like a posterior poem, it is an anterior poem, and all this is done by turning the shaft of the endoscope anti-clockwise. So here we continue with coagulation, with dissection of the submucosal space. The current I currently use is swift coagulation, but you can use spray coag, forced coag, or endocut. The advantages of endocut is faster dissection, but with less coagulation, so an unexpected bleeding may occur. The advantage of swift coag is good coagulation, maybe slower dissection. Concerning spray coag, this is the fastest mode for dissection of the submucosal space, very good coagulation effect. But to be honest, I'm not very well used or trained to use very well the spray coag. I have provoked mucosal damage by spray coag, or I was unable sometimes to use it when water filled the space. Never mind, maybe spray coag is the best current for poem, but I'm not yet used to it. I prefer swift coag. So here the space is tighter, and we continue with careful dissection of the submucosal space. This is an area probably close to the gastroesophageal junction, and this is a high risk area for damage of the mucosal layer. Also, this is an area with the area close to the gastroesophageal junction. It is very rich in the vessels, so slow progression can avoid unexpected bleedings. Actually, in poem, my feared complication is bleeding, because after bleeding we lose our field, and we're not able to see what's going on, and it's not always easy to stop the bleeding. Although I have to admit that most of the times the bleeding stops by itself. So here we are at the gastroesophageal junction, and we can see that we are at the point where we pass into the cardia. And I say that because we pass from a tight space to a wider space, and we see these typical vessels, thin vessels that are typical of this gastroesophageal junction, of this area. So we proceed to dissection of the mucosa. We are at the level of the gastroesophageal junction and we are just entering into the cardia. The reason why I feel confident that we pass into the cardia is because we were in a tight space, and then by further dissection we progress into a wider space. Also we have the typical vessels of this area. We can also feel the resistance of the stricture of Achalasia at this point. Now we have just entered into the cardia, and we dissect carefully the submucosal space. Repeated injections are needed in order to avoid damage of the mucosa. A message that I have captured from other YouTube videos, particularly from Professor Inoue, who has discovered this procedure, is that it is very, let's say, good to damage the muscle layer during the dissection, because that means that we are away from the mucosa and we have the proper orientation for our dissection. When we damage the muscle layer, there is no risk of perforation, because as you will see at the part of the myotomy, we need significant time to make a hole, to perforate the muscle layer and to cut it completely. It is very thick, and just by making superficial damage there is no problem. Anyway, the muscle layer will be ultimately cut, so there is no problem if we coagulate the muscle layer. Now you see that the dissection plane has been changed, and this is very important during poem. Now the muscle is located at the right of the screen at 3 o'clock. Now, when we pass the endoscope from the gastroesophageal junction, we have excessive force that is applied on the shaft of the endoscope, and we have to turn it left or right in order to progress and to slide inside the space. So the problem with this movement is that the dissection plane can change, and we can get lost and continue dissection close to the mucosa, which is located at the left right now. So in case that you have an hesitation, pull back, see what is the line of your dissection, see where is the muscle, and then follow the muscle to understand how to proceed. Now I have changed my coagulation forceps to co-grasper because the previous forceps was very big and occupied a lot of space inside this tight cap. So here I use the co-grasper with soft coagulation 80 watt for dissection of vessels near the gastroesophageal junction. In previous cases I have encountered significant bleedings. Most of them had occurred from vessels at the gastroesophageal junction or the cardia. So this is the part that is very rich and has very, let's say, aggressive or dangerous vessels. Now we check out our tunnel from outside, and you can see that we have just passed the junction, and in retroflexion we will check out whether our tunnel is deep enough into the stomach. Here we have the typical image of whitening of the cardia, whitening due to the adrenaline that it is added into the solution of the normal saline, and blue due to the indigo carmine. Now we are back to the tunnel at the level of the junction. You see the pressure that is applied, and now we just pass the junction and we have entered into a pocket inside the stomach. So our tunnel is deep enough and it is ready for myotomy. Now to be honest, I have not yet concluded in the best strategy from where to start the myotomy. It is better to start from the cardia and then pull back, or is it better to start from the proximal side and then move towards the cardia? What is for sure is that the most tricky part is the dissection and myotomy of the cardia and gastroesophageal junction. And maybe it is better to start from that point. From the other hand, once you have performed the myotomy at the level of the gastroesophageal junction, theoretically, I assume that we provoke capnoperitoneum more easily. So at the moment of my current experience, I'm not sure what's the best strategy. In this case, I started from the most proximal part, 1 centimeter distally to the incision, and I go slowly towards the junction and the cardia. I suppose that in the next case I may start directly from the cardia just to finish with the difficult part, which is actually the most important part for poem, the cutting of the muscle of the gastroesophageal junction and cardia. Never mind, here we're doing the myotomy at 6 o'clock. Despite the fact that this is an anterior poem, I have turned my endoscope and the muscle is positioned at 6 o'clock. This is full thickness myotomy, and a good question is, which is the best setting for myotomy? I don't know. I can tell you that the fastest setting is endocut. But endocut is very good until we reach the longitudinal muscle layer, because normally there are no vessels between them. But if you cut beyond the longitudinal muscle layer, there are some big vessels. And what I suggest is to use endocut and alternate it with a coagulation mode, such as spray coag, which is probably the best setting for myotomy, or shift coag, or even force coag. So here what I do is I tap with endocut a few times just to split the muscle layer, and then I continue with coagulation. In this way I have rapid dissection of the initial fibers, and then have a coagulation effect with the swift coag or whatever setting you're using. Now what I do for myotomy is the technique that I call RNA technique, because it reminds me the copy of the RNA. So I start from distally to proximally, and then I choose a short segment of 3 centimeters. Then I move my endoscope 5 centimeters distally to the previous myotomy, and I try to cut the next segment, and then I connect the 2 segments between them. What is important is to be careful with the movement of the end of the knife, because if you use it from down to up, you may damage the mucosa, which is from the other side. So it is better to use it from up to down and direct the knife towards the muscle and not towards the mucosa. If you use it from the other side, I mean from down to up, be careful not to damage the mucosa. So we are performing the myotomy at 6 o'clock. I alternate endocut with swift coagulation. I repeat that spray coagulation is very good, but I had an interference of the current with my screen. I had some artifacts, so I used swift coagulation or forced coagulation for this procedure. I don't know what it is better, full thickness or partial myotomy. Since there are no complications with full myotomy, I proceed to full myotomy. Even though you will see that just by cutting the transverse layer, then the longitudinal layer is being dissected by itself just by applying the endoscope. So I don't think that it really matters. I just use full thickness just by instinct or for faster myotomy. Maybe an argument against full thickness myotomy could be that if you do full thickness you may encounter more vessels. That's my personal experience. So maybe it is more safe, less bloody, let's say, if you stop your dissection when you reach the longitudinal layer. Now here we arrive at the hot area of the cardia. The dissection is more difficult here for several reasons. Actually, the orientation of the dissection is not quite evident because as you push the endoscope, the orientation changes. Never mind, here at the left we have the mucosa, at the right at 3 o'clock I have the muscle layer, and now we proceed to myotomy. Don't forget that in the cardia we have more vessels, so here we have to proceed slowly, very slow, and probably use more coagulation than in previous steps. One other point is that we provoke a lot of smoke during the procedure and we have to aspirate it. Here we proceed to full thickness and you can see the structures beyond the esophagus that move at the right side at 3 o'clock. So don't be afraid. This is, let's say, normal, and this proves that you have done full myotomy. Look at the vessels that are at the right side. You have to be careful not to damage them. What we see at the left side is the mucosa that protrudes, the mucosa of the cardia and stomach. Now we are at the level of the cardia. We see the peritoneal fat at the right side, and here we have to continue our myotomy. At 3 o'clock we see that the longitudinal layer is not yet dissected, although I repeat, it is not necessary to dissect it, but I feel better to cut everything, every muscle fiber I see during POEM. So here we cut the remaining fibers. Coagulation current is crucial at this part, and what I have also to comment is that friction of our cap to vessels can provoke some minor bleedings that stop spontaneously. From time to time we have to push or pull our endoscope just to verify that our orientation is good and that we continue our line of dissection. Here we have a minor bleeding that will stop spontaneously, which was provoked by friction of the endoscope to a small vessel. Here we dissect the last fibers of the cardia, of the gastroesophageal junction, full thickness dissection or full thickness myotomy of the gastroesophageal junction. Obviously it looks scary, but it is I'm very impressed by the fact that the patients, at least until now, did not encounter any complication. So the procedure is safe according to my experience, and obviously according to more than 2,000 or 3,000 poems around the world. What I have not yet told you is that I give antibiotics just prior to the procedure. I have chosen to administrate tazocine, so piperacillin with what else inside? Tazocine, a very strong antibiotic which covers both gram-negative, gram-positive, and anaerobes. I administrate tazocine for about, obviously during the 2 days of hospitalization, and then I continue with augmentin, which is amoxicillin and clavulanic acid, for a few days. And high dose of PPI is also administered a few days prior to the procedure and during the hospitalization to diminish the acid exposure of the esophagus. Here we cut the last 2 centimeters of the muscle layer of the lower esophagus at the level of the gastroesophageal junction. Here we had a snapshot of the peritoneum, and here at 2 o'clock we have the remaining muscle at the level of the junction. At the right side you can see that we have actually a pseudo-lumen that has been created due to CO2 insufflation, and which is actually the peritoneal cavity, which is quite scary. So here we cut the last fibers just to complete the myotomy, and then we're done. During the procedure you have to ask your anesthesiologist for the endotracheal pressure, which is about 20-23 millimeters of water in this case, and in most of my cases the pressure is about 20 to 24 milliliters of water. Here we confirmed full myotomy in the entire tunnel. Some remaining fibers have to be dissected. Here I dissect from down to up, which is a little bit dangerous. With coagulation current. And now we get out of the tunnel and we have to inspect and verify that the junction is loose. Okay, now we have the tunnel at 6 o'clock. We verify that the length of the tunnel, the length of myotomy is sufficient, and there is no ongoing bleeding, some remaining blood inside the tunnel, and now we inspect the junction and we see how loose it is. In no way there is any stricture or any type of pressure identified. So this subjective feel of the passage of the endoscope across the junction verifies that our myotomy is completed. Now we have to carefully close the mucosal entry by using a few clips. You can use Easy Clip by Olympus due to low cost, but to be honest, when available or when I can afford it for my patients, I place 16mm clips by whichever company is available, like Cook, Life Partners or other companies. So here we use about 5-6 clips to close in a zip fashion the mucosal entry. Don't forget to inspect the entire tunnel for damages of the mucosal layer. In my first cases I had damaged the mucosal layer and I placed some additional clips without any complication. So here we close progressively the mucosal entry. Despite the fact that this is an anterior poem, we have placed our tunnel at 6 o'clock, and now we'll verify one more time that the junction is loose. There is no mucosal damage of the walls of the tunnel. Now we feel confident that the procedure is done. The next day after the procedure, the patient undergoes gastrography esophageal transit in order to inspect any leakage that has to be closed before giving the patient the permission to drink or eat. If the transit is okay, then I administrate liquids only liquids for 1 day, and then some soups for at least 1 week. Second week, very smooth diet like for babies, and after 2 weeks we can progressively increase and start eating more solid food. After three weeks, I permit to my patients to eat a normal diet, but all this is subjective and probably will change in the near future with more experience or with guidelines that will be published by the societies or by experts. Thank you very much for your kind attention. I hope that this video was useful for your next poem or for your first poem. And please, if you like this channel, subscribe and comment or send me some feedback. Take care and see you soon.